This animation gives a basic overview of costing in the NHS in England. What is costing? Cost is the money spent in delivering a service, as opposed to a price, which is the money received for providing a service. Costing quantifies the financial value of resources consumed in carrying out an activity. Within costing in healthcare, we use the terms resource and activity. A resource could be a nurse, doctor, or consumables. An activity could be delivering inpatient care, a surgical procedure, outpatient appointment, or pathology test. Costing in the NHS is about linking the costs of a resource to the activity they carry out. For example, take the cost of a nurse looking after a patient on a ward and then assign that cost to individual patients. Why is costing so important? Costing helps NHS organisations identify why and where costs are incurred and assists services in developing improved patient pathways. Costing data can help organisations to better understand and improve the services they're currently providing. There is a great deal of discussion about improving value in healthcare at the moment. Value is about maximising patient outcomes or improving quality to deliver cost-effective care and not just the lowest cost. Benchmarking locally and nationally becomes powerful when a service begins to look at costs and outcomes together. This helps multidisciplinary teams identify opportunities with a clear focus on improving or maintaining patient care. It is not about creating the most income for the least cost. It is about producing the best patient outcomes at the lowest possible cost, creating an efficient service. This, in turn, allows the organisation to make better use of the remaining available resources. Reference costs. Historically, costing was based on estimates and the use of averages, with organisations calculating costs in different ways. An example of reference costing would be for all the costs of an area, for example a ward or theatre. Some organisations would use a slightly more complex model, splitting costs by department or function. The reference cost collection was used to help determine the money that organisations received for certain activities. However, this process led to a wide variation in the cost of providing a service, and in some cases meant that the income an organisation received was less than the actual cost of providing it. Costing down to the patient level. In 2015, Lord Carter's review of efficiency in hospitals outlined the huge inconsistencies in the approaches to costing in the NHS. It also stressed the importance of accurately reporting data. Better costing information will allow healthcare providers to make the best possible use of resources, evaluate clinical practice, compare different ways of working. NHS England and NHS Improvement's Costing Transformation Programme sought to address these inconsistencies, improve the quality and use of costing information in the NHS with the implementation of patient-level information costing systems, or PLICs, across acute, mental health, ambulance and community providers. PLICs presents highly granular information on the actual care individual patients receive, which allows an NHS team to identify their costs at an individual patient level. This transformation has changed the meaning of costing in the NHS. Patient-level costs can now support a multidisciplinary team to identify unwarranted variation in the delivery of patient care. If inputted and recorded accurately, patient-level costing can identify individual drug administrations or prostheses and match them to individual events. Similarly, other costs, such as operating theatre overheads, can be allocated based on the actual length of time it takes for a patient to undergo their operation. This gives a more accurate picture of individual episodes of care and creates the potential to identify warranted or unwarranted variation between different patients undergoing the same types of activity. In other words, a form of internal departmental benchmarking becomes possible, without the issues of comparability that external benchmarking encounters. Fundamental to achieving this level of detail is a flow of accurate information from many different sources in the trust, which are brought together in a costing model. Data required for this includes who sees the patient, how the patient is treated and what they are treated with, their diagnosis, comorbidities, complications, and what treatments have been used in interventions on that patient's journey. To ensure this is a robust data set, each of these stages need to be accurately recorded and coded. The future of costing. So far, the implementation of PLIX has been most extensively used in procedure-based specialties, where costs are easier to determine and allocate. Costing is not limited to reporting just HRGs in the acute sector. The data can report in many ways and across many sectors where costs have been harder to accurately allocate, such as medical, mental health and community services. Tariff reimbursement has stopped for the moment because of COVID, but NTC will continue in order to support tariff development and new payment structures. Locally, if multidisciplinary teams, MDTs, can create regular and protected time together, there continues to be a significant opportunity to work collaboratively with this rich patient-level information, improve its quality, and begin using it to improve patient outcomes whilst reducing any unnecessary consumption of resources. The focus can then begin to truly be on a patient's pathway as it moves through trusts, integrated care systems, and primary care networks. In summary, understanding the cost of NHS patient care is vitally important, both locally and nationally, in making decisions about how to manage and deliver sustainable, high-quality services. As we move towards working as a system, data will be shared more easily, and PLIX information will be the underlying data set, which links one organisation to another, and over the next 10 years, we will begin to have more acute and mental health clinicians, general practitioners and finance professionals strategically discussing pathway redesign in an empirically robust, data-driven way. In turn, this will lead to evidence of marked system-wide improvements in both cost and patient outcomes.